Professor Battegay to give his talk concerning unsolved problems in infection.
Thank you very much. I would like first to thank the organizer for kindly inviting me, in particular Dr. Löffler and Professor Patrick Hunziger. And I will talk in this sprint presentation on unsolved problems in viral infections, especially also on the never-ending story of emerging infectious diseases. You see here a world map, and here in yellow depicted the emerging viral diseases of the last 30 years, among them HIV, Ebola, West Nile, and so on, also MERS. So new viral diseases are often emerging infections due to a new dissemination, often from the animals to the humans, but also to changes in hygiene, climate, and travel. And also there are new patient groups, for example, transplanted patients with severe viral diseases. I come first to HIV because it got a model for all viral diseases. The first report was issued in 1981. HIV was detected 2 years later. It took 2 years, not 8 hours for sequencing HIV. Here you see the electron microscopy showing the virus. Here you see the greatest progress actually in the therapeutic field so far, I think, in human mankind. You see here the life cycle of HIV, the cell cycle, and there are different drugs impairing the replication of 10 billion times a day to almost zero. So the most important drugs are inhibitors of the reverse transcriptase, then the inhibition of the integration of the virus in the cell nucleus, and finally the protease inhibitors, which inhibit the assembly of the virus. Most often 3 drugs are given, and one should take them every day. What are the problems, the challenges? One is the occurrence of resistance. You see here that darunavir, a protease inhibitor, is in the middle of the active site, and you see all the changes in the enzyme allowing that the virus replicates. The same is true, unfortunately, for the newest drug class, the integrase inhibitors. Also there, changes take place so that the virus can replicate. There is almost no changes of mortality left. However, you see that there are 35 million people living with HIV worldwide, and there are 2 million new infections every year till this day, especially in sub-Saharan Africa, but also in Eastern Europe, in Russia, and the Ukraine. Still, 1.5 million people die of AIDS, despite the fact that if patients take the drug daily, then there is close to no mortality difference. We assume that a 20-year-old person now obtaining the infection will live another 55 years. The prevention of HIV is a huge problem. You see here, abstain faithful. Of course, there is an efficacy of 100%, also condoms. Male circumcision, importantly, has an efficacy of 70%. But there is a conflict of interest. The conflict of interest lies in evolution. Life is sexually transmitted. I think we forget that. It's not about only promiscuity, but it's also really that this is inbuilt in evolution. So I think there was a big change in the recent years, and I would like to show the problems for the vaccine development. And actually we have to go back to the origin of HIV. You see here Kinshasa in the 1920s, and you see here the spatial dynamics. Originally, HIV was transmitted from a chimpanzee to humans. And what is amazing is that the phylogeographic history shows the very, very high evolution of different viruses. And of course, this is a huge problem for the vaccine development. You see here the scale. And to show that in comparison to influenza, you see here the distance marks the divergence of the sequences. You see here the global influenza epidemic, 1996. And you see below a single individual 6 years after the infection, and when you compare that, the evolution is as much as several million of people regarding influenza. And of course, these changes of the virus are very problematic. And here I obtained a very nice slide from Alexander Turkola, and you see here summarized the challenges. The first picture shows a heavy glycosylation. It's really like a cake. You don't see the structure under it. Then there is a high genetic diversity, and unfortunately, not as we thought in the beginning, HIV does not look like a gooseberry with spikes, but rather like a football you cannot hold on. And then there are further problems like conformational maskings, and also the immune-dominant regions which would be recognized by the human body, immune system, are shielded by a V1, V2 loop. So there are clearly roadblocks for the HIV vaccine development. We do not understand everything, the transmission from host to host. We don't know also the peculiarities of the virus, envelope, proteins, and we need to understand much more about neutralizing antibodies, how they can be elicited in a broadly neutralizing way. There is a major progress in the last years, and it was lauded as the major breakthrough by the journal Science in 2011. In serodiscordant couple, one person HIV positive, one person HIV negative, if treatment was started early, there was only one transmission. If treatment was started later, 27 transmission. In a more formal partner study we also conducted here in Basel, the center was in Denmark, it was proven that there was no single transmission if patients were treated, properly treated, in 44,000 sexual condom-less contacts. This is a major breakthrough regarding epidemiology, but of course it needs treatment which are taken, and I will come to my wish for nanomedicine. So the continuity of care is what now moves really WHO UNAIDS. It's a huge problem to get people tested, that people are then cared for with treatments. And finally, they are not lost to follow up. And you see here the treatment cascade, which is catastrophic. Only when you have 100 people who are HIV infected, most are not known to have HIV infected, and you end up virally suppressed with 29. In Russia, I learned at the WHO meeting, it's 12%. In Switzerland, it's between 70 and 80%, still not perfect. So this is a huge challenge, and I may say so, a huge market. So the wish here for, of course, nanomedicine is a deliverable, also affordable system. Patients have to take drugs once a month or even less. The two issues I will touch upon are much shorter. It's the Ebola virus with mortalities up to 75%, an enveloped RNA virus, also a zoonosis, so from animals to humans. Here are the first cases where almost all died in Guinea, and the epidemiology shows that now there are over 27,000 cases with over 11,000 dead patients. Although we are controlling the epidemics, of course, this can and probably is likely to reoccur if the transmission pathway cannot be impaired from the fruit bats to the humans, if we don't have vaccines, if we don't have treatments. So just to illustrate you what are the challenges also for viral diseases working, this is actually the Twitter messages, and nobody is really interested, but when healthcare workers, and this is understandable, are involved to care patients, this was the highest frequency of Twitter messages for a healthcare reason ever encountered, and you will see that at once. That was one person infected actually in Spain. You remember the lady. So the pathogenesis, I will not come to it, but obviously the inflammation cannot be controlled. Treatment, just shortly, we have the antibodies which seem to work in single patients. However, this is not affordable and you cannot treat many patients. And there are other antiviral drugs not specifically targeted to Ebola, like the old Cidofovir. The vaccine issue, actually for Ebola, much more optimistic than for HIV because it's an acute infection, and there are now phase 2, phase 3 studies looking if there is an efficacy. The last 2 slides, or 3 slides, there is a newly emerging virus from camels to humans, the Middle East Respiratory Syndrome corona, MERS virus, a coronavirus. There were over 100 deaths already reported. Now also in South Korea, you see the numbers by 24th of June. And of course, it is also, again, up to sequencing and sequencing camel viruses to see how the transmission takes place, and also if the transmission takes place from human to humans, which seems in a limited way the case. So this is my last slide. These are the unsolved problems. They lie in the triangle of environment, host, and pathogen. And you see all the problems with the transportation system, with the megacities, and of course also with the pathogen, which often originates by animals and which is transferred to humans or reappearing because people are not vaccinated, like against polio, measles, or influenza. And with that, I thank you very much for your attention.
So thank you very much for this very interesting overview. Since we are a little bit over time, I would like to ask somebody who is Laszlo, one short question.
Very short. In Ebola, as you know, it has a very high death rate. If you are able to go ahead and come up with something that will keep the patient alive by stopping the hemorrhage, is that an effective strategy, even though you're not removing the pathogen?
Interestingly, we had to learn that the hemorrhage in many patients who died was not the main problem, the huge hemorrhage. So the viral hemorrhagic fever was not the problem. It was really the loss of fluid in the third space. So the replacement of fluid was up to 40 liters. Also in Basel, we prepared for averaging 20 liters. So to stop that fluid to go to the third space is the main problem. Actually, the huge bleeding was also only observed in 10% of the cases.
So, one more question, since Beat gave me the time.
You mentioned antibodies being too expensive, but I mean, there may be an issue at scale, but in fact, in terms of cost, there's very little difference between antibodies and NCEs.
Yeah. So antibodies administer, of course, for our world is perfect. However, these diseases are occurring in Western Africa, in the poorest countries. So I think that is an issue to make them affordable and also deliverables. But, of course, especially for acute infection and a post-exposure prophylaxis, for example, for families, that would be perfect to limit an epidemic outbreak.